told here at the storytelling night. Next, I'm going to invite on stage one of my old teachers and a teacher of my teachers, Dr. Chitramali De Silva, to tell the story of establishment of MCH services and covering services across life cycles. As you all know, Dr. Chitramali De Silva is a legend in MCH services in Sri Lanka. As the Deputy Director of Family Health Bureau, her leadership and guidance helped maternal and child health services to be implemented according to international standards. Ladies and gentlemen, as we all know, MCH services put us on the map of public health all over the world, and we owe it to many people like her who have worked tirelessly in their life to bring Sri Lanka so forward in MCH services. It's my great privilege to invite Madam you on stage. A round of applause to her.
Good evening to everyone, my teachers and all the colleagues, sirs and everyone who are here today. So I think everyone was talking about many stories about their personal experience and also how the health system has been developed. So let me take you to see the remarkable journey of maternal and child health services through our history of health services in Sri Lanka. So, have we successed, or whether are we improving, or so there is a dilemma. But anyway, there are so many things that have been happened over the years. So, I think Dr. PSC would have started from here. So, this is how the health unit system was established in 1926 in Kalutara NHS area, where this Vinnabutana, that is the public health midwife, who was the one, that is the landmark in our history, where the appointment of public health midwives were trained in 1926, based at, and I first started at BMH Hospital and then in Kalutara NHS area. So always this motherhood is considered as a very precious condition in every society. So I think that may be the reason even in Sri Lanka, the first maternity hospital in the whole Asia was established in Sri Lanka. The Disoisa Maternity Hospital. That was in 1879, a long way back in 1879. And then only this public health midwife training was started, and the attention was given to provide, first starting with the clinic-based care and then moving towards the domiciliary-based care for the pregnant mothers. And then later on only the newborn and the child care was incorporated. So at that time, we had a very high maternal mortality rate, nearly 2,400 per 100,000 diapers at that time. But then there were a lot of home deliveries, and home deliveries were unskilled because there were no skilled persons to do the deliveries at home. So maybe there were so-called traditional birth attendants, the husbands of the women, the spouses. So all those people were used to, and also the traditional people who have been doing this work right at home. So they were doing like that. So, but then the government took a very strong decision. So expanding the hospital services will take a lot of time. So therefore, first we should promote skilled home deliveries by a skilled person. And that is how the midwives were trained to first to do the home deliveries at home. So I can remember when I was a small girl, right? When I was just starting the schooling, the midwife who was wearing this boiled sari, a cantian with the blue line on her sari, and carrying the delivery bag, walking around the streets or even the villages and coming and reminding about the immunization, vaccination. I can still remember the lady who was working in my village at that time, somewhere in 1960s. So anyway, that was the big achievement. And then what happened was, with the skilled birth attendance, our maternal mortality ratio became very much less. And then only from 1940s onwards, the country decided that we should expand our hospital services and to promote more of hospital deliveries, because the complicated cases cannot be managed by the midwife alone. So this is the clinic center is this maternal child welfare clinic center. So that is the clinic services where the woman comes and get the services at the center also. That is how the MCH clinics was established. And the midwife was first, they were just going by foot, and then they were given push cycle. And I can remember how I wrote a cabinet paper to give the midwives a moped, and then later on the scooter, right? So that is how the mobility of the midwives were also improved over the years. We took decisions at our National Family Health Steering Committee and how it was evolved over the years. But now our midwives are privileged with a scooter to move about. And also she is providing a lot of domiciliary care starting from pregnancy, pre-pregnancy. Now we have expanded the services to cover the pre-pregnancy, pregnancy, and whole of the life cycle care. So another important thing is the nutrition of the children and the mothers. So that has to be given priority. I think as Dr. Susmira also mentioned about the nutrition policy and the multi-sector involvement, those are important. And she used to have this, she's still having this village-based field weighing post where the every child is measured, and their weight is growth is monitored properly, and also the domestic care is also provided. And the important program in our school, our MCH program, is the school health program, which has a very long history. It was started in 1920s. So I can remember how I